Jai Hind. Manisha, I think ma'am is there. We can start.
Okay, ma'am. Okay.
Jai Hind, ma'am. Very good afternoon. Thank you
Yeah,
for
good
joining.
afternoon, ma'am.
Thank you. Thank you so much. Jai Hind to everyone who are present over here. So today is the second day, and we are having eminent speaker with us, Dr. Aparna Pandey, madam, and she is a principal in a government college of nursing. And the detail will be uh, shared with the other sides with the other. I think I'm audible to everyone. Echo, हो रहा है, sir. I think.
Yes, ma'am. Yes, ma'am.
Is a echo? Is a echo from my
No,
side?
no, ma'am. No, ma'am.
Okay. Thank you so much everyone for joining today. And today we are going to deal with the digestive disorder by Dr. Aparna ma'am. Thank you so much, ma'am, for joining us and giving your time and blessing to the participants with your eminent knowledge regarding the Department of Medical Surgical and the disorder related with the digestive system. Thank you so much. On behalf of Samarpan Institute, I heartily welcome you. I heartily welcome all the participants which are joining today. Thank you so much. I now uh, request to Sakshi or the management to deal with the next part. Thank you so much.
Thank
A
you.
very good afternoon and warm greetings to one and all present here. I, Mrs. Manisha Vincent, Assistant Professor of Samarpan Institute of Nursing and Paramedical Science, extend a heartfelt welcome to all the dignitaries, esteemed speakers, respected faculty members, students, and guests who have joined us from across the country for the national webinar series on redefining nursing practice focus on adult health and surgical care. Before I proceed, I would like to express my heartfelt gratitude to our respected Principal Madam Dr. Deepti Shukla Madam for giving me this wonderful opportunity to stand before you and host this part of the program. Her constant encouragement and trust in me truly mean a lot. Thank you, Madam. Now, moving forward to the highlight of this movement, it is indeed a privilege to introduce our esteemed speaker for the day, Dr. Aparna Pandey, Madam. Ma'am currently serving as a principal cum professor at Government College of Nursing, Shahjahanpur, Uttar Pradesh. She holds a PhD in nursing and a master's degree in medical surgical nursing with a career spanning over 18 years of teaching experience. She honored with the Best Researcher Award by the Innovative Education and Scientific Research Foundation in the 5th National Editor Summit 2023. She certified as a master trainer for HIV/AIDS and TB under GFATM, endorsed by the Indian Nursing Council 2015. She recognized for guiding 5th PhD scholars, 6 postgraduate MSc Nursing, and 6 postgraduate BSc Nursing research projects. Ma'am authored and published 7 research articles with scholarly work covering topics such as chemotherapy, drug safety, insulin administration, cancer pain, and hepatitis B, and cranial nerve assessment. She served as a university paper setter, internal external examiner, paper evaluator, and research mentor. She has actively contributed to over 15 national and institutional seminars, workshops, and training programs. Ma'am holds professional memberships with TNAI and UP State Nurses and Midwifery Council. She known her leadership in academic administration and dedication to evidence-based nursing education and research. Today, we are fortunate to have her here with us to share valuable thoughts on digestive system disorder, and I am confident that their words will leave us enlightened and motivated. So, without further ado, please join me in welcoming Dr. Aparna Pandey, Madam, with a big round of applause. Over to you, ma'am.
Thank you, Manisha.
Thank you, ma'am.
It's really a privilege and honor for me to be among you all people over here on this platform. to share my views on the digestive system disorders. And I hope I'll be able to fulfill the needs of the students, those who have joined today for this webinar. So could you please share my PPT?
Yes, ma'am. You can share.
Yeah.
Ma'am, are you sharing? Whether we can share from our side?
Ma'am, you please share from that side.
Okay,
Okay,
please,
ma'am.
Shashank, you share.
Yes, ma'am. Yes, ma'am. Is it visible, ma'am?
Yeah, visible, visible.
Okay.
Yes.
ma'am. Can we start?
So a very warm good afternoon to one and all present on this occasion. So here today I would like to discuss about the various gastrointestinal disorders. So before moving on to the various gastrointestinal disorders, I would like to discuss about briefly the anatomy and physiology of the gastrointestinal system. As we all know that the gastrointestinal system starts from the oral cavity, then lies the esophagus, stomach, small intestine, large intestine, the rectum and the anus. And there are certain accessory organs also which help with the process of the digestion. So we have the teeth, the tongue, the salivary glands, which secrete the salivary amylase, the liver, the gallbladder, as well as the pancreas. So these accessory organs secrete certain things which is helpful during the process of digestion. The whole of the abdominal region has been divided into 9 regions. That is, we have the right hypochondriac region, the epigastric region, left hypochondriac region, the right lumbar region, the umbilical region, left lumbar region, the right iliac region, the hypogastric region, the left iliac region. And the whole of the organs, what are being distributed in these regions is also visible to you. Like the right hypochondriac region may consist of your liver as well as a part of the stomach. And then the abdomen is also divided into the 4 quadrants. That is the right upper quadrant, which consists of the liver, gallbladder, ascending and transverse colon. The right left quadrant, which consists of the lower small intestine, ascending colon, appendix, and the intestinal obstruction usually occurs over here. The left upper quadrant, where the stomach, spleen, and transverse descending colon is present, and the left lower quadrant, where the descending colon and the rectum is present. And usually what the problems what we have with this region is your intestinal obstruction, constipation, and enteritis. There are various diseases based on these regions and quadrants. We can just have a glance of that. So which is visible in this picture. Like the epigastric region, you have the esophagitis, the peptic ulcer, perforated ulcer, pancreatitis, biliary tract diseases. The right upper quadrant, you may have the gallstones, hepatitis, liver abscess. And in the left upper quadrant, you may have the spleen abscess. Similarly, moving to the umbilical region, the early signs of appendicitis may be visualized over here. Then you have the Meckel's diverticulitis. the right lumbar region, we may get the renal colic, and the other diseases like the ovarian cyst and the ovarian torsion. The left lumbar region, again, it is related to your renal colic, the pyelonephritis, and the ovarian cyst and masses. The right lower quadrant, appendicitis, Crohn's disease, and in the pelvic region, that is the lower region, you may have your urinary retention, cystitis, and all. And the left lower quadrant, you have the diverticulitis, ulcerative colitis, constipation, etc. And before moving on to that, I would like to just discuss the physiology in brief. That is, all these organs together, they help in the process of digestion. And the function of the GI system is to digest the food and then absorb the essential nutrients as well as the water in some amount back into the body, so that the nutrients are maintained within the our human body and our functions are being maintained. And because of the various problems occurring in the GI system, the nutritional status may be altered in the human body. And the need is that we should be able to assess. So we'll next slide, we'll see the assessment of the GI system. So the assessment is totally focused on evaluating the functions of the digestive tract. And as I have already told, it starts from the mouth and it ends in the anus. So the assessment can be done based on the subjective data, that is the patient's history, where the patient may complain, that is the chief complaints of the patient, where the patient may say that he is suffering from abdominal pain, nausea, vomiting, diarrhea, or constipation. Then we will look into the history of the present illness, where we will try to find out, that is, when the disease has started, what was the duration of the disease, where the actual problem is located, what are the various symptoms the patient is showing, and what are the aggravating factors for these symptoms. And next, we will also look into the past gastrointestinal history, where we will try to find out that previously also whether the patient was having any GI problems, or the patient had any surgeries related to the GI system, or the patient is on any medications related to the GI system, or maybe for some other system also, because as we know that the NSAIDs or some other drugs may also impact the GI system. Then the medication history of the patient, that is currently and previously what medications the patient has been taking, whether the patient is taking any over-the-counter drugs or any herbal supplements. And then is the dietary history, that is the food pattern of the patient, whether the patient is a vegetarian, non-vegetarian, or what kind of food allergies the patient is having, or any intolerances the patient might be having. And the bowel habits, that is the frequency, consistency, and the color of the stools also will be collecting the data. Next is the smoking, social history, where we will be collecting the history of the smoking, alcohol consumption, and any substance use like tobacco and all. And next is the family history, whether in the family there was any history of GI related disorders, because we know that some of the diseases are transmitted genetically. Next is the objective assessment. This is nothing but the physical examination. And here we will be doing the inspection, that is visually with the help of our eyes. We will just inspect the abdomen and we'll be looking for the distension, scar, any masses or visible peristalsis. And auscultation, which is usually done with the help of the stethoscope. We will be listening for the bowel sounds. And then comes to the percussion, where we will be tapping with the help of our hands placed on the abdomen, and we'll be assessing for the fluid or the masses or any gas present in the abdomen. And next is the palpation, where we'll be having, that is in the palpation, it comes as the deep palpation and the superficial palpation. So by doing that, we will be detecting for any tenderness, masses, or organomegaly. And the other things what we'll be doing is we'll be assessing the oropharynx, that is the mouth and the throat, and we'll be checking the hydration status of the patient to look whether the patient is properly hydrated or not. And we'll also assess the perianal area for the presence of hemorrhoids or fissures and fistulas. Yes, next slide. Next, before moving on to the various disease conditions, in short, I would like to discuss about the various diagnostic tests, what we do. As we are all are aware that for confirming the diagnosis of a disease, we need to perform certain diagnostic tests. So in the GI system also, we may have to perform certain diagnostic procedures, which will be helping us to diagnose the disease. And the purpose of this diagnosis is to identify the digestive disorders like ulcers, gastritis, inflammatory bowel disease, celiac disease, or else to identify the various infections such as the parasitic infections, and then the tumors, that is the polyps or the colon cancer, any structural abnormalities like strictures and blockages, and the functional disorders such as the motility disorders and the acid reflux. Next slide. So first thing in the diagnostic test we are doing is the blood test. As we all are aware that there are changes in the blood reports when a person is suffering from an infection or any other diseases. So if through the blood investigation, we may get a confirmation about the various infections or the inflammations that have been occurred in the GI system. Then is the stool test or the stool examination, where we may examine the stools for the presence of the occult blood or the presence of any infections. Then is the imaging studies, where we have the X-rays. So we may perform the X-rays in order to visualize the GI tract, which may be either a plain X-ray or usually in combination with the barium. And then we perform the ultrasound. Through the ultrasound, we can be able to assess the soft organs like your liver, gallbladder, and intestines. Then we may also perform the CT scans, because at times the ultrasound may not give us the clear picture. So for that, we may perform the CT scan of the GI tract. And other than that, we may also do the MRI scan. Next, we have certain endoscopic procedures. As we all know, endoscope is nothing but it is a flexible tube that can be inserted into the openings or the cavities. So this endoscope usually has a camera on the tip of it, and with the help of the GI tract. So in the endoscopic procedures, we have the endoscopy, we have the sigmoidoscopy, we have the colonoscopy. And with the help of these scopies, we will be able to visualize the inside of the digestive tract. And the other test what we have is the esophageal manometry, which helps to measure the movement and the pressure inside the esophagus. Then we have the hydrogen breath test, which helps us to detect the bacterial overgrowth or the sugar intolerance. And we have the barium swallow and the barium enema, after which we may be taking the X-rays for the patient. Yes, coming on to the disease condition. So the first disease condition what I would like to discuss with you all today is the peptic ulcer. So we all are aware that the term peptic represents the stomach. And as we all know, ulcer is nothing but it is a break in the continuity of the mucous membrane. So what happens in the peptic ulcer is the mucosal lining of the stomach is usually eroded because of the action of mainly the H. pylori bacterial infection. And at times it may be also because of certain medications such as the non-steroidal anti-inflammatory drugs. So you can see in the definition, it is defined as a break in the continuity of the mucous membrane of esophagus, stomach and duodenum by high levels of pepsins and acids. And the other definition says that it is because of the H. pylori infection. Next slide. Next, we have the classification of the gastric ulcer. It is also known as the modified Johnson classification for the gastric ulcer, where it has been classified into 5 types. So the type 1, the location is your gastric body or the lesser curvature, which is visible in the image, which is present at the bottom of this table. So here there is no hypersecretion of the acid, and the complication, that is bleeding, is uncommon, and the incidence of this is 55%. Next is the type 2, which occurs in the body of the stomach and the duodenal ulcer. And here there is hypersecretion of the HCl, and complication is bleeding, perforation and obstruction, and the incidence is 20%. The third type is prepyloric, Over here also there is an hypersecretion of the HCl and bleeding and perforation occurs and the incidence is again 20%. And the fourth type is high on lesser curvature, and here there is no hypersecretion of the acid and bleeding is present and the incidence is less than 5%. And the fifth type can occur anywhere in the stomach, and here there is no hypersecretion of the acid, but again here the bleeding and perforation may be seen and the incidence is less than 5%. Next is the incidence. So commonly we'll be discussing about two ulcers, that is your gastric ulcer and the duodenal ulcer. Esophageal ulcer will not be dealing over here. So the gastric ulcer, the age is usually 50 years of age or above that, and the duodenal ulcer 30 to 60 years of age. The male to female ratio in gastric ulcer is 1:1, and in duodenal ulcer it is 2 to 3 males to 1 female. And the 15% of the peptic ulcers are gastric and 80% of the peptic ulcers are duodenal. Next, coming on to the etiology. As I have already told you, the main causative factor over here is the H. pylori infection. So what happens is this bacteria, it disrupts the stomach's protective mucosal layer, and thus the acid which is present inside the body may means inside the stomach may be damaging the mucosal lining. And the other etiological factor is the non-steroidal anti-inflammatory drugs such as your aspirin, brufen, and naproxen, which can again inhibit the production of the protective prostaglandins, leading to decreased mucus production and increased acid production. There are certain risk factors also, which we'll be discussing in next slide. So the risk factors is smoking, excessive alcohol consumption, and the alcohol can irritate the stomach lining and interfere with the ulcer healing. And the other factors which may contribute to peptic ulcer is your stress, eating spicy foods, as well as old age. Next, coming to the clinical manifestation. So the person who is suffering from the peptic ulcer may complain of abdominal discomfort or pain, nausea, pain radiating to the back. This occurs in case of ulcers which have penetrated into the stomach, and then the burning or gnawing feeling similar to the hunger pains, pain aggravated by meals in case of gastric ulcers, and pain that is relieved by meals in case of duodenal ulcers. Now we have compared both the gastric as well as the duodenal ulcer. The gastric ulcer symptoms do not follow a consistent pattern. Eating sometimes exacerbates rather than relieves the pain in case of gastric ulcer. While in the duodenal ulcer, they tend to cause more consistent pain, and pain can awaken the patient at the night, and pain is relieved by food. That is, if the person takes the meals, within the pain will be relieved, but within 2 to 3 hours, once again, the patient may start to feel the pain in case of duodenal ulcer. Again, the signs and symptoms. In duodenal ulcer, hypersecretion of the HCl, that is the stomach acid, and the patient may have weight gain because here the person's pain relieves after taking food. So very frequently the person may consume the food, and pain occurs 2 to 3 hours after a meal, and the person often awakens between the sleep, that is 1 to 2 a.m. early in the morning, and ingestion of food relieves the pain. Vomiting is uncommon. Hemorrhage less likely than with the gastric ulcer, but if it is present, melena may be seen, and more likely to perforate than the gastric ulcers. Malignancy possibility is very rare in duodenal ulcer, and the risk factors over here is the H. pylori, alcohol, smoking, cirrhosis, and stress. Whereas in the case of gastric ulcers, there is normal or hyposecretion of the HCl. Weight loss may occur. Pain occurs within half an hour to 1 hour after a meal, and it rarely occurs at the night, and it may be relieved by vomiting. And ingestion of food does not help in the pain, and usually the ingestion of food may increase or enhance the pain, and vomiting is common. Hemorrhage is more likely to occur than in case of the duodenal ulcer, So here the patient may show the symptoms of hematemesis, whereas in their duodenal ulcer, there was melena. The malignancy is occasional over here. And again, the causative factor over here is H. pylori, gastritis, alcohol, smoking, and NSAIDs, and the stress. This is a just picturized representation of the peptic ulcer disease. Move on to the next slide. Next, coming on to the diagnostic evaluation. So, when we are measuring the serum gastrin and the serum calcium levels, so high levels of these hormones may indicate a more serious problem, such as the gastrinomas. These are the tumors associated with a rare gastroenterological disorder called as the Zollinger-Ellison syndrome, and multiple endocrine neoplasia, also known as MEN, a disorder in which the endocrine glands are overactive to form a tumor. And then testing for the H. pylori infection, as we know that the causative factor is the H. pylori infection. And other than that, we may also do the barium contrast radiography. That is, the barium meal may be given and followed by an X-ray. And the gastrointestinal endoscopy, that is visualization of the GI tract with the help of an endoscope. Next, coming on to the complication. The person may have bleeding in the stomach or the duodenum. And then a hole called a perforation can be seen in the stomach wall. There may be a blockage and stomach cancers. Next, coming on to the treatment. So here the main treatment is related to the reduction of the gastric acid secretion. So in the this category, we may have the H2 antihistamines and the proton pump inhibitors, the anticholinergic drugs. These drugs helps to reduce the gastric acid secretion. The examples of H2 antihistamines is cimetidine, ranitidine, famotidine, etc. The proton pump inhibitors are omeprazole, lansoprazole, and pantoprazole. Anticholinergic drugs are uh, pirenzepine and propantholin. And then coming on to the antacids, these are the prostaglandin analogs and systemic and non-systemic. Here you have your misoprostol, sodium bicarbonate or sodium citrate, magnesium hydroxide, magnesium trisilicate. And then you have the ulcer protectives, that is, these are the drugs which helps in protecting the mucosal layer and thus prevents the formation of the ulcers. So you have the sucralfate, then colloidal bismuth subcitrate. Then you have the ulcer healing drugs, that is, once the ulcer formation has taken place, then there are drugs which helps in the healing process of the ulcers, in which we have the carbimazolone, sodium. And next is your anti-H. pylori drugs such as amoxicillin, metronidazole, tinidazole, and tetracyclines. So these drugs somewhere directly or indirectly help in treating the peptic ulcer. Next slide. Next, coming to the surgical management. So in case of peptic ulcer, which is very severe, we may go for the surgical management where we may surgically remove a part of the stomach. So we have the first surgery that is known as the enterectomy, where the lower part of the stomach is removed by cutting. And next is your vagotomy, that is cutting the vagus nerve. So when we cut the vagus nerves, it helps in reducing the HCl production. So these are the two surgical management. Next, coming to the lifestyle changes, which is very essential in the peptic ulcer. So first is avoiding the non-steroidal anti-inflammatory drugs such as aspirin. So we have to avoid those drugs. Then avoiding alcohol, tobacco, and caffeine. As we all know, the risk factors for peptic ulcer may be the consumption of alcohol, tobacco, as well as caffeine. So these have to be cut short or these has to be stopped. Next is dietary adjustments or modifications where the person should take small and frequent meals. So this will be helping to worsen the condition and the person has to quit smoking. Next slide. Next, coming to the nursing management. So the focus of the nursing management is basically to relieve the pain and prevent the complications, at the same time enhance the nutrition of the patient and educate the patient regarding the peptic ulcer. So first comes the pain management, where as a nurse we are supposed to administer the various drugs as per the physician's order, like your antacids, H2 blockers, proton pump inhibitors. This helps to reduce the pain and give relief to the patient. And we also have some non-pharmacological pain relief measures where we can use the biofeedback mechanism, distraction of the patient, and guided imagery can also help the patient in the pain management and reducing the anxiety. Next is prevention of the complications. As we all know, the perforation may occur, which is one of the complications of peptic ulcer, as well as the bleeding may occur. So first of all, we have to monitor for the bleeding as well as hemorrhage. So we have to, if the patient is vomiting, we have to check for the presence of blood in his vomit. And as well as we have to check for the presence of blood in the stools of the patient. And we have to assess for any decrease in the blood pressure, which may be an indication of a complication. Next is the nutritional support. We have to see that the person consumes adequate nutrition. So small and frequent diet can be given to the patient. And at the same time, the person has to avoid the oily and spicy foods. Next is the patient education, where we may educate the patient about the medications the patient is taking, how the patient can modify his lifestyle, that is, avoid all the unhealthy habits and stick on to the healthy habits, and the dietary guidelines, that is, the diet the patient is supposed to take, the stress management, where the relaxation techniques can be taught to the patient, and then we have to ask the patient to come for the follow-up visits so that the patient can get a complete cure. And then we have to promote the nutrition, where we have to make the dietary modifications and then the regular meals. Next is addressing the anxiety and depression. So as we know that the anxiety and depression or the stress is also one of the causes which can aggravate the peptic ulcer. So here we need to see that we provide the emotional support to the patient. That is, we have to support the patient, reassure the patient, and help the patient to cope up with the stress. And then we have to teach the coping techniques to the patient, where we may even teach some yoga, because we know that in yoga we have the relaxation techniques. And then we have the monitoring and evaluation, where we have to continuously monitor the patient, as already discussed, and the pain assessment, nutrition status, and evaluation of the interventions what we have done for the patient. Next slide. The next topic what we will be seeing is the hernia. As we all know, hernia is nothing but it is a protrusion of an organ through a weakened organ or a hollow cavity. So hernia occurs when an organ or a tissue protrudes through a weakness in the surrounding muscle or tissue, and this can happen in various locations, most commonly in the abdomen or the groin, and usually appears as a bulge. There are various types of hernias. In the picture, it is visible. We have the epigastric hernia. Then we have the umbilical hernia, incisional hernia, inguinal hernia, and the femoral hernia. The umbilical hernia is very common in the newborn children. And in the male, it is usually the inguinal hernia that is very common. Incisional hernia occurs in the patients who have undergone a surgery, and because the surgical part is usually weak, so because of that reasons, if the healing process has not occurred properly, then the patient may have the incisional hernia. And similarly, the femoral hernia, which is usually common in the females. And then you have the epigastric hernia. Next slide. So here the various types have been discussed, and I already have told you about this. Go to the next slide. Next slide, please. Yes. Now coming on to the hiatal hernia, this is one of the most common types of hernia, where the part of the stomach is pushing into the chest cavity through a weakness in the diaphragm. We have various types of hiatal hernia, that is paraesophageal hiatus hernia, where the stomach is sliding through the weakened diaphragm into the that is the chest cavity. Next is your sliding hiatal hernia, where the stomach pushes through the weakened diaphragm and the sphincter, esophageal sphincters, and moves up. And then you have the sliding and paraesophageal hiatal hernia, which is a combination of the above two. Next. Next, the causes of hernia is the weakened muscle. So just weakness in the muscle is not sufficient for a hernia to be caused. There are certain other contributing factors also. That is, if the muscles are already weakened and the person is doing certain strenuous activities, such as heavy lifting. So what happens is a pressure is generated and the organs nearby to the weakened area moves through the weakened part and the hernia is caused. Then you have the congenital hernia, which is nothing but the hernia which is present by birth. So as I have told you, the umbilical hernia is the one which is present in the newborn children. And this usually happens because of the incomplete development of the abdominal wall. Next is the injury or the surgery. So the incisional hernia, this is one of the examples of your injury or the surgery where because of the weakened abdominal wall, the organs nearby may move through that incision or that injury. And next cause is your straining or lifting of the heavy objects. Next. Risk factors may include being overweight or obese, pregnancy, having a chronic cough, constipation, and straining during defecation. So as we all know that if you're obese or you're overweight, there is usually a very huge pressure in the abdominal region. Similarly, in the pregnancy also, because of the growing fetus, it does not give adequate space. So the pressure inside the abdomen may be increased. And a person who is having cough, so we know that while coughing also, pressure is the pressure in the abdomen increases. Similarly, during the constipation or straining activity also, the pressure increases. So these are some of the risk factors which may cause hernia. Symptoms may include bulge or a soft lump in the groin area of the abdomen, a feeling of heaviness or discomfort around the bulge, a pulling or dragging sensation where the bulge is present. Next. Next is the diagnostic evaluation. That is how we will diagnose. So usually the hernias are visible through physical examination itself. That is when you examine the patient, you can find the bulging, especially through your visual eyes also if the hernia is severe, and on palpation also you can feel the organ. Then is the imaging studies, that is the ultrasound, the CT scan, MRI and X-ray are helpful in identifying and diagnosing the hernia. Next. Other tests may include your endoscopy. This is usually done in the case of the hiatal hernia. So, the endoscope is inserted orally into the stomach, and with the help of the endoscope, we can identify the size and the location of the hiatal hernia. And next is your barium swallow. Again, this also helps to identify the location where the hernia has occurred. And next is your esophageal manometry, where we can identify or measure the pressure inside the esophagus. Next. Next, coming to the management. So, the medical management, that is with the help of the medicines. So, we have the antacids that neutralizes the stomach acid. So, the Gelisil and these all antacids helps in reducing the stomach acid. Hence, it neutralizes the stomach acid. So, the regurgitation and all that things don't happen. Next is your prokinetic medications. That is, these will be reducing the pressure of the lower esophageal sphincter and by causing the lower esophageal sphincter to contract with greater force, thus reducing the chances of reflux. That is, the gastric content will not be able to reflux and thus it will reduce the chances or it will minimize the hernia. Then we have the proton pump inhibitors. Again, it is helping in reducing the acid production within the stomach. And then you have the histamine blockers like ranitidine and cimetidine. So the mechanism of action is again the same. That is, it helps to lower the acid secretion, and it thus reduces the pressure inside the stomach indirectly. Next. Next, we have certain surgeries, that is the Nissen fundoplication. So in this surgery, we are usually doing it to strengthen the lower esophageal sphincter. So here a part of the stomach is taken and then it is wrapped around the lower esophageal sphincter and then it is stitched over it. So this procedure involves a 360-degree fundic wrapping around the lower gastroesophageal sphincter, and thus it strengthens the lower esophageal sphincter. Next one. Next is your Belsey's fundoplication. Again, similar to the Nissen fundoplication. And again here, in that it was 360 wrapping, but in this it is only 270 degrees wrapping. And again here it is in order to reduce the incidence of gas bloating and post-operative dysphagia. Next. Next, coming to the nursing management. So the first is the pain management. So we may be administering the analgesics for reducing the pain, and our focus as the nurses should be the non-pharmacological pain management techniques. So here we may use the cold compress on the affected area so as the pain can be reduced. And then is preventing the complications. So we have to monitor for the signs of hernia, strangulation, such as increased pain, redness or tenderness, and that has to be reported immediately. And we have to assist the patient in maintaining the positions and help the patient to reduce the discomfort and prevent hernia from worsening. And for this, we may even elevate the head end of the bed. Next. Next is the preoperative and postoperative care. So as we all know, preoperatively, we have to reassure the patient and we have to make the patient ready for the surgery. So we have to provide all the clear information regarding the surgery and what are the pre-medications the person has to take and how the patient has to be on fasting before the surgery. And after the surgery also, what are the various measures the patient is supposed to take have to be instructed to the patient preoperatively. And postoperatively, as nurses, we are supposed to monitor the vital signs of the patient. We have to assess the surgical site for the signs of infection or any redness or any kind of bleeding or presence of pus. And we have to encourage the early ambulation, as we know that early ambulation helps in the faster recovery of the patient. So we have to encourage the patient for early ambulation, and this will also help to prevent the complications like the deep vein thrombosis. And again, in the patient education, we may instruct the patient to avoid lifting heavy objects, and how the body mechanics should be maintained by lifting the objects also have to be taught to the patient. And we have to advise the patient how to maintain a healthy weight and what are the measures the patients can take in order to reduce the weight, and the various dietary advice has to be given to the patient. Next. The next important topic, which is commonly seen, is the hemorrhoids, which is also known as the piles. So hemorrhoids is nothing but these are the swollen veins, also known as the varicose vein, which after swelling may be bulged out. So in commonly, it is also known as the piles, and it is seen in the rectum and the anal region. Next. So the types is external hemorrhoids as well as the internal hemorrhoids. External hemorrhoids develop in the skin around the external anal opening, and the symptoms may include swelling or feeling a lump around the anus, discomfort, pain if the blood vessels get thrombosed, that is the clotted blood, bleeding of the skin over the hemorrhoids tear. Next is the internal hemorrhoids. Internal hemorrhoids lie inside the rectum. Usually they cannot be visualized outside until and unless they are coming into the fourth stage. There are various stages of the internal hemorrhoids. So in the first and the second stages, the hemorrhoids cannot be visualized outside. And here the person may have irritation while passing the stools, and the painless bleeding may occur during the bowel movement, and the person may notice bright red color blood in the stools, and means sometimes these hemorrhoids may even prolapse outside the anal canal. Next. Next, why the hemorrhoids are caused? So first is straining during the bowel movements, sitting for long periods of time in the toilet, having chronic diarrhea or constipation, being obese, being pregnant, faulty bowel function due to overuse of laxatives or enemas, eating a low fiber diet, and regular heavy lifting. Please excuse me for a minute.
Okay, ma'am.
Sorry for the interruption. Actually, I had an urgent call. So now we will continue. There are various grades of internal hemorrhoids. So internal hemorrhoids may be graded into four. That is the grade 1 and grade 2. Grade 1, there is no prolapse, just prominent blood vessels may be seen. And in grade 2, there will be prolapse upon bearing down, but there is a spontaneous reduction. In grade 3, there will be a prolapse bearing down and it requires the manual reduction. And grade 4, the prolapse with inability to manually reduce the hemorrhoids. Next is the symptoms. Bleeding during the bowel movements, protrusion of skin during the bowel movements, feeling of a lump coming out of the anal canal while passing the stools, itching in the anal area, pain in the anal area, and sensitive lumps. Next. Next is the diagnostic evaluation. So on the physical examination, when we will examine the anal area of the patient, we may be finding the lumps in and around the anus, and there will be swelling and irritation, which can be visualized around the anal region. Then is the digital rectal examination. Over here, the nurse puts onto the gloves and applies the lubricant jelly and then inserts the finger into the rectum in order to check for the muscle tone and feel for the tenderness, lumps, and other problems. And next is to diagnose the internal hemorrhoids. We can also do the anoscopy, sigmoidoscopy, and the colonoscopy. By doing this, we can visualize the anal canal. And by visualizing the anal canal, we can get a clear picture of the degree to which the hemorrhoids is present. Next. Next is the complications. Complication with regard to the hemorrhoids is very rare, and usually because of the blood loss that occurs during the means when the patient is having the hemorrhoids, so it may result in anemia in the patient, and there may be even strangulated hemorrhoids. This occurs in the case of the internal hemorrhoids, and when a person is suffering from a strangulated hemorrhoid, it causes an extreme pain. And sometimes even the blood clots may also occur. These are known as the thrombosed hemorrhoids. Although they are not very dangerous, but they are extremely painful. and sometimes they need to be lanced and drained. That is, it needs to be, with the help of a lancet, we need to put a incision over there and then drain off the blood. Next, treatment. That is eating a high fiber diet and taking over the counter fiber supplements. That is 25 to 35 milligrams per day of fiber may help to soften the stools and make it bulky. Avoiding excessive straining to reduce the pressure on the hemorrhoids and help prevent the protrusion. Drinking more water to help prevent hard stools and aid in the healing process. Taking warm tub baths, also known as the sitz bath, 10 to 20 minutes every day may also help in the healing process. And the person can also apply the ice packs, as the ice packs can ease the pain as well as the swelling. Next is the surgery. So, especially in the case of the type third degree and the fourth degree of the internal hemorrhoids, or in case of the severe hemorrhoids, the surgery may be needed. So, the various surgery that can be performed for hemorrhoids is hemorrhoidectomy, where we may cut and remove the hemorrhoided tissue. And then is the rubber band ligation, that is also known as banding. That is, a rubber band is placed around the base of the hemorrhoid and slowly, because it is so tightly packed that it cuts off the blood supply and it will help the hemorrhoid to shrink and then fall off. Then is the stapled hemorrhoidoplex, where here the hemorrhoidal tissue is again tied off, and then we are stapling it to prevent the blood flow to go into the hemorrhoidal region, and then it is being treated. And then last one is your sclerotherapy, where a chemical is injected into the blood vessel of the hemorrhoid and it shrinks. Next, as we have seen in the previous slides also, here the focus of the nursing management is to relieve the symptoms and prevent the complication and promote the healthy bowel habits. So in the pain management, the first is the sitz bath, where the person is advised to take warm sitz bath 10 to 15 minutes several times a day so that it can soothe the area and reduce the swelling. Next is your topical medications, that is certain creams and ointments can be applied, and there are suppositories available which can help as pain relievers and anti-inflammatory as well as vasoconstrictors. And next is promoting the bowel regularity. So here the person may be advised to take high fiber diet, maintain adequate hydration, and then stool softness may be prescribed to the patient. Next. Next is avoid straining. As we have seen that when the person strains a lot, it results in worsening of the hemorrhoids. So we have to educate the person to avoid the straining. So the person has to maintain a regular bowel habit. So maintaining the regular bowel habit helps to prevent the constipation. So the person need not sit in the toilets for the long hours. Next is the perineal hygiene. And here we have to teach the patient that how the person can gently cleanse the perineal region after each bowel movements, as well as dry the area in order to prevent any kind of irritation. And next is your lifestyle modification, where the person can be taught for the weight management, that is the weight reducing activities, as well as the regular exercises. Next is your prevention. So it can be prevented by the help of high fiber diet, where the person can be advised to eat more amount of fruits, vegetables, whole grains. So the high fiber diet helps in softening the stools as well as increasing its bulk, and help the person not to strain during the time the person is passing the motions. Then drinking plenty of water again helps to soften the stools, and then the fiber supplements, that is 20 to 30 grams per day, can also help. Next. Next, advise the patient not to strain while passing the stools. If the person is suffering from the problems of constipation, then we can advise the patient to take the stool softeners. And we have to advise the patient to go for defecation as soon as the person feels the urge to defecate, because if the patient keeps waiting, then the urge goes away and slowly the stools becomes harder. So we have to advise the patient to go to the washroom immediately as the person feels the urge to go, and the person has to stay active to help prevent the constipation, because if a person is having a job where the person has to sit for long hours, so sitting for long hours or standing for long hours may help to develop the constipation. And if the constipation develops, it is natural that it may worsen the hemorrhoids. So again, for that, we have to advise the patient to avoid long periods of sitting as well as standing. Next. Next is the fissures and fistulas. Anal fissures are nothing but these are the small tears near the anus, and a fissure which is not treated properly may land up into a fistula. A fistula is nothing but it is an infected tunnel between the skin and the anus, and this may occur because of frequent anal abscess or the fissures. Next slide. Next is the causes. Causes of fissure may be passing of hard stools or constipation, chronic diarrhea, any trauma to the anal region, inflammatory bowel disease, rough anal intercourse, and sexually transmitted infection. Next is the causes of fistula. The causes of fistula may be an infection, an abscess, an untreated fissure, and inflammatory bowel disease. Symptoms. In the fissure, we may see a tear in the skin around the anus, pain in the anal area during the bowel movements, streaks of blood in the stools, burning or itching in the anal area. While in the fistula, there will be frequent anal abscess, pain and swelling around the anus, bloody drainage, fever, chills, and fatigue. So these are the images which are telling the differences. First is the hemorrhoids, next is the fissure, and the last one is the fistula. So now we'll discuss the differences between three of these. Next. So here I have made three columns. In the first, I have mentioned the hemorrhoids, next is the fissure, and next is the fistula. So first is the hemorrhoid, that is when the vein in the rectum swells up, causing an internal hemorrhoid. It is known as the piles. A fissure is nothing but it is a tear that occurs around the anal area, is known as a fissure. And fistula is nothing but it is a tunnel which connects an infected gland inside the rectal wall to an area of the skin. This is called as a fistula. Causes is, for hemorrhoids, the causes may be chronic constipation, straining to pass the stools, low fiber diet, family history, and pregnancy. Causes of fissure is inflammatory bowel disease, tight anal sphincter, frequent diarrhea, and laxative abuse. While for fistula, it can be infected anal glands by the bacteria, diseases which weaken the immune system, rectal disease, and Crohn's disease. Next, coming to the signs and symptoms. In hemorrhoids, there is painless rectal bleeding. There is constant discomfort in the rectum even when empty, and a constant itching is felt in and around the opening of the anus. In fissure, the blood is released from the anal opening during the bowel movements. Pain during and after the passing the stools. A crack is easily noticed around the opening of the anus. Whereas in a fistula, pus is released from the anal opening. A redness, soreness, or itching sensation is felt around the opening of the anal area, and pain during the bowel movement. Next. Next is the treatment. For the hemorrhoids, we can go for the laser hemorrhoidoplasty. It is used to treat the hemorrhoid so as to destroy it. Next is the sclerotherapy. Again, as we have discussed earlier, here we are injecting a chemical which is helping in shrinking the hemorrhoids. And next is the rubber band ligation, where the hemorrhoid is tightly bound with the help of the rubber bands to cut off the blood supply. For the fissure, the laser surgery, it helps in quickly healing the fissure, and then topical anesthetics and applying the nitroglycerin. And in the fistula, again, the laser surgery, it helps to quickly uh, heal the fistula. And then is the seton placement. It is done in the case of deep fistulas. Seton is nothing but it is a drain which is connected, and it is draining all the pus that has been formed in that particular area, and it helps in the healing process. And next is the fistulotomy, where an incision is made into the fistula tract in order to drain the pus out. Next. Next is the prevention. So if we see all the three, in the prevention, it says that drinking plenty of water may be helpful, whether it is a hemorrhoid, it is a fissure or a fistula. So drinking lots and lots of water may help in easing all these three problems. Similarly, eating a high fiber diet, whether it is a hemorrhoid, it is a fissure or a fistula. So eating a high fiber diet or a fiber rich diet helps to prevent all these three problems. And similarly, exercising regularly may also help. And washing the anal area with the warm water regularly may help in uh, treating these three problems. Next. So these are the prevention in all together. That is prevention for both hemorrhoids, fissures as well as fistulas. So avoid straining while passing the stools. Don't hold the defecation. As soon as you feel the urge, you have to immediately visit the washroom and defecate. Next, eating a high fiber diet can help in preventing all these three. Drinking plenty of fluids. Regular exercises helps in improving the digestion and eases the defecation process. Do not misuse the laxatives. Uh, just for stool softening, very often we should not use the laxatives. Rather, we have to modify our diet, and do not sit too long. Try to move around whenever it is possible, and try to reduce your weight if you're obese. Next. The next topic what we'll see today is pancreatitis. As we all know, the term pancreatitis itself tells us that it is nothing but it is an inflammation of the pancreas. So acute inflammation is in the pancreas that occurs suddenly and usually resolves in a few days with treatment. Acute pancreatitis may be a life-threatening illness with severe complications. Next. Next is the prevalence of the pancreatitis. So if we see around 28 lakh 14,972 cases of acute pancreatitis have been noticed in the year of 2019. That is 4.1%. That is 1,15,053 of them met their demise. That is, they passed away. And according to a study published in 2021, India is one of the top 3 countries that have got the greatest number of cases or incidences of acute pancreatitis. The other countries are China as well as America. Next is the causes of acute pancreatitis. So the causes may include heavy alcohol consumption, that is around 40%, the gallstones, also known as the cholelithia, that is the pancreatic stones, and that is the cholelithiasis, that also is one of the causes. And the other factors that is responsible for causing the pancreatitis may include your abdominal trauma, use of certain medications, infections, tumor, then genetically, that is if someone in the family was already having this problem, the next generation may also suffer, then high triglyceride levels and high calcium levels. Yes, next. Next slide, please. Then other causes such as the estrogens, corticosteroids, thiazide diuretics are the medications that may result in pancreatitis. Then the previous pancreatic surgeries, severe injury to the abdominal area, viral infections such as mumps, then coccidiosis B, Mycoplasma pneumoniae, Campylobacter infections, and an abnormal structure of the pancreas. These are some of the other causes that may result in pancreatitis. The signs and symptoms may include severe abdominal pain after having the food, pain in the upper abdominal region, which usually goes towards the back, rapid heartbeat, upset stomach, fever, unwanted weight loss, nausea and vomiting, stinking and oily stools, tender and swollen belly, diarrhea, bleeding, and dehydration. Diagnostic evaluation. So, as I have told previously, also the blood test and the stool test can be done. So, the changes in the blood report are indicative of infections. Similarly, when we are doing the stool test, the presence of the enzymes or the blood and all may be indicative of certain problems. So, here in the blood test, we may see the amylase or lipase, and the stool routine examination for the digestive enzymes of the pancreas may be also done. And in case of pancreatitis, it may be elevated 3 to 4 times from its normal range. And then we may even do the radiological investigations, that is the imaging studies. So X-ray may be performed after a barium meal, and ultrasonography can be also helpful in identifying the problem. Other than that, we may also do the endoscopic ultrasound. Endoscopic examination will help to evaluate the pancreatic masses, tumors, and pancreatic cyst, small stones in the bile duct and the gallbladder, which is usually unnoticed by the ultrasound. Other than that, we may also do the CT scan, MRI scan, then magnetic resonance, cholangiopancreatography, and PET scans. These are all the non-invasive non-invasive things, and they help in diagnosing the pancreatitis. And then we can also do the ERCP, that is the endoscopic retrograde cholangiopancreatography. So it helps to even visualize. At the same time, it also helps in removing the gallstones. Next, complications. So the complications that may occur over here is the malnutrition due to the lack of the digestive enzymes, diabetes due to the insulin mismanagement. As we all know that it is the pancreas which secretes the insulin, and when it is infected, it is natural that it may result in insulin mismanagement resulting in diabetes, pancreatic infection, kidney failure, and then is the pancreatic cancer, fatigue and dehydration due to diarrhea, necrotizing pancreatitis, that is the tissue death inside the pancreas due to limited blood supply, pancreatic pseudocyst. Pseudocyst is nothing but it is a false cyst where the fluid collection occurs in the pancreas. Lung problems such as the breathing difficulty can be also seen. Next is the treatment. So here we can give the pain medications and the antibiotics to lower down the infections. And then the intravenous fluid therapy may help to prevent the dehydration. And then is a low fat diet or fasting, as it helps in the faster recovery of the pancreas. Next. Surgery. The surgery may include cholecystectomy, that is, if the gallstones are present, so it has to be removed because it is one of the causative factors for pancreatitis. So as we treat the gallstones, automatically we can treat the pancreatitis. And next is the endoscopic retrograde cholangiopancreatography. Again, the same thing in order to remove the gallstones, because if they are removed, so it will remove the blocking of the bile and the pancreatic ducts. Then the other procedures that can be performed is gallstone removal, then sphincterectomy for the pseudocyst drainage, balloon dilation, that is to dilate and stretch the bile duct so that it can be kept open. Then is the stent placement and the pancreatic surgery such as distal pancreatectomy, then pancreatoduodenectomy and total pancreatectomy to clean out the fluid or the dead or diseased tissue and to transplant it. Next. The next topic what we'll see is hepatitis. So hepatitis, it is the inflammation of the liver, often caused by a viral infection. And the causative factors again here may be the alcohol consumption or the drug abuse as well as autoimmune disorders. There are various types in hepatitis. We have hepatitis A, B, C, D, and E. As we all know that hepatitis A and E, these are usually spread through the contaminated food and water. So these are usually the foodborne or waterborne diseases, the hepatitis A as well as E. The hepatitis B, C, and D. These are very infectious as they are spreading through the bodily fluids, that is your blood, semen, etc. So the hepatitis B, C, D, these are very contagious and they may get transmitted from one person to another person through the contact with the blood as well as semen or through the exchange of the needles or syringes. Next. Next is the transmission of infection. As I have already told you, hepatitis A and E, they are spread through contact with the contaminated food as well as water. And hepatitis E is usually caused because of undercooked pork, deer, or shellfish. And hepatitis B, C, D, they are caused through direct contact with the blood or this semen or serum. And hepatitis B and D may also spread through other contaminated body fluids, and they may also happen because of sharing of the needles and having unprotected sex. Stages of hepatitis. So the first stage is known as the incubation stage or the incubation period. This is the time between the infection and the first symptom. That is when the person has contracted an infection and the time when the person starts to show the signs and symptoms. So this period is known as the incubation period. And during this phase, the virus is actually replicating within our body. So during this process, the person may not show any kind of symptoms because the virus is still replicating inside the body. And this incubation period may last from 2 weeks to 6 months. Next comes the prodromal phase. In the prodromal phase, the person may show the flu-like symptoms. That is, here the symptoms are visible now. So the person will be showing the flu-like symptoms, fatigue, and nausea and vomiting and the muscle pain or the joint pains. And the person may also show the signs of fever, rashes, and swollen glands. And the next stage is your, please say the slide. Next is your icteric phase. Now the jaundice becomes apparent. That is total yellowing of the skin and the white of the eyes, that is sclera, also becomes jaundiced. Urine may turn dark in color. That is the straw-colored urine may be seen, and the stools may be pale yellow or clay-colored stools may be present, and liver enlargement. And in the right upper quadrant, the patient may complain of pain, and this may last from several days to several weeks. Next is your convulsant phase. This is the phase from the prodromal to the icteric phase starts to resolve. Here the patient may be feeling fatigue and malaise, and it may last 2 weeks to months together. And here the liver values, that is all the enzymatic values, may start to return to the normal. Next. So this is some of the symptoms what we may see, that is jaundice, itchy skin, easy bruising, dark urine color, abdominal pain, swelling in the legs and ankles, nausea and vomiting, pale colored stools, then chronic fatigue and loss of appetite. Next. Next, coming to the diagnostic evaluation. Here we can assess for the serum transaminase. The alanine transferase is elevated. Aspartase transferase gets elevated. Alkaline phosphatase gets elevated. And in chronic hepatitis, the low LDH also gets elevated. Next, coming to the serum protein, the albumin decreases. In chronic hepatitis, the immunoglobulin G increases and the ratio of A and G decreases. The urobilinogen increases in the early stages of acute hepatitis. The direct bilirubin and indirect bilirubin also increases. And test for antibody is positive. And next is the prothrombin time is prolonged. The blood ammonia is elevated. The ultrasound examination may show a bulky liver, and the LFT is deranged, and we may also perform the liver biopsy. Next, coming to the management of hepatitis. So first of all, we have to advise the patient to take adequate rest and adequate nutrition, restrict the hepatotoxic drugs, and avoid any toxins. Hospitalization is usually not required in a mild condition. The patient may take rest at home, and through the dietary management, it can be cured. But when the case has become complicated, the person may require an hospitalization, and we have to monitor for the blood pressure, the urine output, heart rate, as well as look for any dysrhythmias. Then start an IV line. Avoid ringer lactate as liver has the inability to metabolize the lactate. Always look for the fluid overload if you're giving the IV therapy. And in case of fluid overload, we have to prescribe the diuretics so that the fluid overload can be reduced. Next is albumin and protein supplements may be required depending upon the serum albumin levels. So if the serum albumin levels are very high, we have to see that we have to avoid the albumin and protein supplements. Next is serum electrolytes needs to be checked timely and it has to be corrected. And next is feeling of nausea and vomiting can be corrected by given antiemetics. Next is look for the coagulopathies. Look for the bleeding gums, epistaxis, petechiae, hematuria, and monitor for the serum coagulation profile, that is PT, PTT, CT, INR, and injection vitamin K may also be prescribed if coagulopathies are present. In the event of hepatic encephalopathies, measure the lower ammonia levels, and these include oral administration of lactulose, neomycin, and metronidazole. And if a patient has become comatose, then we have to insert the nasogastric tube. And then the lactulose is laxative that acidifies the colon to prevent the absorption of ammonia. And neomycin and metronidazole clears the colon of the bacteria that produces the ammonia. A topical skin ointment can be applied to elevate the pruritus, that is the itching. And then you can also give the alpha interferon 5 million units daily to 10 million units 3 times weekly for 4 to 6 months, which results in remission of the disease in approximately 1/3 of the patients. And oral nucleoside analogs like entecavir and lamivudine can also be administered. Next is the liver abscess. So this is nothing but it is a pyogenic abscess and it is caused by an infection due to an illness or a trauma. So as we all know, abscess is nothing but it is a pus-filled cavity. So here the pus gets filled in the liver. Liver abscess is a local accumulation of the pus-filled cavity within the liver. The abscess causes an increase of the pressure within the liver as well as killing the healthy tissues surrounding the liver. The end result can be that an overwhelming infection can suddenly gain entrance into the bloodstream, at which point the patient gets extremely sick and with blood poisoning. Abscesses caused by the bacteria or parasites or by the use of the needles. Next. There are various types. So you have the pyogenic liver abscess, you have amoebic liver abscess and the fungal abscess. Pyogenic denotes that there is collection of pus within the liver. Amoebic liver abscess is the result of the amoebia, that is a parasite, and the fungal abscess was caused because of the fungi. The most common type is your bacterial as well as the parasitic infection. Next. So this is the figure which shows your amoebic liver abscess. Next is the causes as well as the risk factors. So the abdominal infections such as appendicitis, diverticulitis, or the perforated bowel, these may be one of the contributing factors for causing the liver abscess. As we all know that these are the organs which are situated very near to the liver. Next is in any infection in the blood. It may also cause your liver abscess. Then infection of the bile draining tubes, that is your cholangitis. Recent endoscopy of the bile draining tubes. Trauma that damages the liver. Amoebic dysentery, immunodeficiency, metastatic liver cancer. Then we have your entamoeba histolytica, enterococcus, E. coli, Klebsiella, streptococcus, and staphylococcus. These are some of the common bacteria causing liver abscess. So when a person is suffering from a liver abscess, the person may complain of pain in the right upper quadrant, and then nausea and vomiting may be present. The person may show the symptoms of weight loss, right-sided chest pain, jaundice, fever and weakness, dark urine and chalk-colored stools, joint pain, loss of appetite and general discomfort. Diagnostic evaluation. Here we may do the abdominal CT scan, the ultrasound, bilirubin blood test, blood culture for the bacteria. CBC may be done for identifying the infection, liver biopsy, liver function test, and the WBC count, which is usually elevated. Next is the management. So prompt treatment of the abdominal and other infections can reduce the risk of developing the liver abscess. So if the person is suffering from any other disorders or diseases or infections of the GI tracts, like such as the diverticulitis or peritonitis, if we are treating it at an early stage, then the chances of the person contracting the liver abscess can be reduced. And it can be also treated with the help of the chemotherapy, antibiotics, or the needle aspiration. Surgery may be done for the patient where the liver abscess may not be resolved by giving the medications. Antibiotics are used over several weeks in order to prevent the recurrence. Next is the antimicrobial therapy may be given. That is 750 milligrams of metronidazole 3 times a day for 10 days may be given. Next slide. Next, coming to the surgical management. So the surgical treatment of the liver abscess includes the drainage of the abscess with the help of a needle or a small tube that is inserted through the abdomen. And this surgical procedure is called as the laparoscopic or percutaneous drainage and aspiration. And along with this, we can also give the antibiotic therapy. Next. So the nursing management over here is focused on reducing the fever. So for reducing the fever, the first and foremost activity that can be done by the nurses is to continuously monitor the vital sign, where the nurses can check for the temperature, pulse, respiration, as well as the blood pressure. And in case the temperature is high, then we can give the cold compress or the tepid sponging can be done. Then we can administer the antipyretic drugs, and we have to increase the oral intake of the patient. If the patient cannot tolerate orally, then the IV fluids may be given to the patient. And we can also relieve the pain by giving the analgesics and by giving the comfortable position to the patient. And then we can suggest the patient to perform the deep breathing exercises, and we can also use or apply the compress over the area where the person is having pain. Next. Here we have to administer the soft diet or the low residue diet, also known as the hepatic diet. And painkillers can be given only as per the orders, and antacids may be given. And we have to provide the knowledge to the patient about his condition, and we have to relieve the anxiety of the patient and help the patient or induce the sleep in, that is, help the patient to sleep properly. Next. Next slide. Next is your liver cirrhosis, that is the scarring of the liver. It is a chronic degenerative disease in which the normal liver cells are damaged and they are replaced by the fibrous or the scar tissue. Scar tissue replaces the healthy liver tissues, partially blocking the flow of the blood through the liver. Thus, the liver is not able to function properly, resulting in the liver failure. And in this condition, the liver becomes very hardened and lumpy in appearance. Next. Next is the classification of the liver cirrhosis. Next slide. So we have the alcoholic cirrhosis, post-necrotic cirrhosis. Alcoholic cirrhosis, as the name itself suggests, that it is commonly seen in the people who are having the habit of alcohol use. That is, those who are the chronic alcohol takers. So they usually suffer from the alcoholic cirrhosis, where because of the excessive use of the alcohol, it results in the damage to the liver tissues and also the malnutrition in the person. Next is the post-necrotic cirrhosis. So here it is occurring in 10 to 30% of the cases, where it may be because of certain toxic agents or certain infections such as viral hepatitis. So because of that, the liver cells, they die and they become necrosed. Next. Next is your biliary cirrhosis. So it is because of the problems occurring in the bile duct. So because of that, the liver becomes very much inflamed and damaged. So biliary cirrhosis scars or fibrous tissue are formed in the liver around the bile ducts, and it results in a chronic obstruction to the bile duct and infection of the bile duct, that is known as the cholangitis. Next is your cardiac cirrhosis. It is associated with severe right-sided long-term heart failure, and this is very rare. Next, causes and risk factors. So here, the long-term heavy drinking of alcohol is one of the foremost cause for causing the liver cirrhosis. Next is congestive cardiac failure, and then chronic viral hepatitis, that is type B, C, and D, non-alcoholic fatty liver disease, cryptogenic cirrhosis, biliary atresia, Wilson's disease, any surgery of the gallbladder, cystic fibrosis, autoimmune hepatitis, alpha-1 antitrypsin deficiency, glycogen storage diseases, galactosemia, and toxic hepatitis. These are the causes and risk factors. These are the symptoms what we can see in liver cirrhosis. So the most, that is the cardinal signs, if we say, the cardinal signs may be your spider angioma, the xanthoma, jaundice, the paper money skin, gynecomastia, then hepatomegaly, then caput medusae, ascites, palmar erythema, then finger clubbing and the white nails, and bloody spots. So these are the cardinal or the main signs that we can see in the liver cirrhosis. Other than that, what we can see is the person may complain of malaise as well as fatigue, anorexia and weight loss, feeling of enlarged abdomen may be there, the swollen abdomen or legs may be seen, nose bleeding may be present in the patient, jaundice and itching, that is the pruritus, can be seen, and hand tremors. Next slide. See, this is caput medusa. If we see that there are protrusions in and around the navel area, that is the umbilical area. So in the first, it is very mild, and in the second, the caput medusa is very severe. Next slide. Next is the diagnostic evaluations. So, like for any other disease conditions, we can here also do the history collection and physical examination as well as the blood investigations. So other than that, what we can do is the CT scan, the ultrasound, the MRI scan can be also performed. Next slide. Coming to the management. So here, eating a very nutritious diet so that the malnutrition can be prevented, and the sodium restricted diet is recommended for the patient, and then the vitamin and mineral supplements is necessary, as it may help in promoting the healing to the liver cells which has been damaged, and it helps in improving the nutritional status of the patient. Next. And if it is caused due to alcohol, we have to immediately ask the patient to stop drinking. So if the person stops drinking, then it will help to break the progression of the disease. That is, the disease will not progress further. And in case it is a caused because of the virus, so we can give the antiviral drugs so that it will reduce the damage to the liver cells. And if it is autoimmune disorder, liver cirrhosis, then we can start with the steroids therapy, and so that it can suppress, these medications can suppress the immune system. Next. Next is your potassium sparing diuretics for treating the fluid retention in the legs, that is the edema as well as the ascites. And we can also administer the oral antibiotics in order to treat the infection and improve the liver function. And usually we prefer to give the intravenous antibiotic therapy in case of the liver cirrhosis. Next is hepatic encephalopathy is treated by cleansing the bowel with lactulose A laxative given orally or in the form of enemas. And the patient is advised to reduce the intake of dietary protein. And some people with cirrhosis who have developed the hepatorenal failure must undergo regular hemodialysis treatment. As we all know what is hemodialysis. So this process helps to remove the waste from the blood, and medications can help to improve the blood flow through the kidneys. Next. Laxatives can be given in order to prevent the constipation, and it also helps to reduce the chances of the poisonous substances from the bowel to bypass into the liver and reaching the brain, causing the drowsiness, confusion, and coma. Then vasopressins may be used to treat the bleeding esophageal varices, and beta blockers or nitrates may be given for the portal hypertension, and beta blockers can help in reducing the pressure in the varices and reduce the risk of bleeding. Next slide. Next is the patient education and health maintenance. So first of all, the person has to give up the alcohol consumptions completely. Then we have to give in written to the patient about the various dietary instructions, such as avoidance of the protein-rich diet and including more of vitamins and minerals in the diet. Then we have to advise the patient to plan for the alternate periods of rest and ambulation. And while the patient is taking bed rest, the legs should be elevated so that the edema can be treated and the ascites also can be treated to some extent. Then encourage the person to gradually increase the exercises, and the daily weight monitoring has to be done in order to check if means the weight should not increase over here. Our motto is to reduce the weight of the patient and encourage the high calorie, moderate protein meals. And we have to discuss with the patient the adverse effects of the diuretic therapy. And then we have to stress and give importance for the continued follow-up cares. Next. So we'll discuss the nursing management later on. Next. Next slide, please. Next is your portal hypertension. So portal hypertension, it is a vascular disease wherein the blood pressure increases in the portal vein and its branches. So that's why it has got the name of portal hypertension. Portal vein, as we all know, it is the large blood vessels that carry the blood from the abdominal organs to the liver. Portal hypertension is defined as a portal pressure gradient of 12 millimeter of mercury or greater and is often associated with the varices as well as ascites. Next. So what may be the causes of the portal hypertension? So we have three different classification of the causes. So we have the prehepatic cause, hepatic cause, and the posthepatic cause. The prehepatic cause for the portal hypertension can be a congenital atresia or the stenosis, thrombosis of the portal vein, thrombosis of the splenic vein, compression by the tumor, arteriovenous fistula, and massive splenomegaly. The hepatic cause, that is the cause directly related to your liver, can be the hepatic cirrhosis, acute alcoholic liver disease, congenital hepatic fibrosis, idiopathic portal hypertension, primary biliary cirrhosis, vitamin A toxicity, and cytotoxic drugs. And the post-hepatic causes can be constrictive pericarditis, right-sided heart failure, and veno-occlusive disease. Next. The clinical manifestation of portal hypertension may be abdominal pain, gastrointestinal bleeding, varicose vein of the esophagus, that is also known as esophageal varices, black tarry stools or blood in the stools known as melena, blood in the vomiting, development of fluid in the abdomen known as ascites, decreased platelet count, jaundice, hepatic encephalopathies, and spider angioma. Next. So this is a picture showing the esophageal varices, which can be seen in the esophagus with the help of the endoscope. And next is the spider angioma, which can be visual directly. That is, on inspection, we can find the spider angiomas on the skin. If you see, it is giving the appearance of the spider. Already I have shown the picture of the caput medusae. So these are nothing but these are the dilated veins which can be seen around the umbilicus or whole of the abdominal region, that is in the umbilical as well as the periumbilical region. And next is your gynecomastia, pruritus, that is widespread itching, fatigue and weakness, increased irritability, altered sleep pattern, and weight loss. Next. What are the consequences of the portal hypertension? So this portal hypertension can result in increased pressure in the peritoneal capillaries, resulting in ascites. On the other hand, it can cause portosystemic shunting of the blood. This portosystemic shunting of the blood can result in the development of two different aspects, that is development of collateral channels, that is the caput medusae, the hemorrhoids, as well as the esophageal varices. On the other hand, shunting of ammonia and toxins from the intestine into the general circulation, causing the hepatic encephalopathy. And the portal hypertension again is responsible for the splenomegaly, which is resulting in anemia, thrombocytopenia, and leukopenia. So these are the consequences of getting the portal hypertension. That is, it is going to affect the other areas also. Next, coming to the diagnostic evaluation. So again, there is no simpler way to test to show if a person is having a portal hypertension. So it is usually done based on the presence of ascites or dilated veins or varices as seen through the physical examination of the abdomen or the anus. We may perform certain lab tests like the liver function test, glucose monitoring, FBC, clotting screens, X-ray test, and endoscopy examinations may be done in order to identify the other problems like the esophageal varices or other aspects, because portal hypertension cannot be directly measured. And for some patients, we may also do the biopsy, and the CT, MRI, and ultrasounds may also be done to see the dilated veins or the enlargement of the spleen. Next. Management includes endoscopic therapy. This is the first line of treatment for the variceal bleeding and consists of either banding or the sclerotherapy. Banding is a procedure in which a gastroenterologist may use the rubber bands to block off the blood vessels. And sclerotherapy is nothing but it is a process wherein the sclerosant solutions are used and it is injected into the bleeding varices so that to cause help in the scar formation. Then the medications what may be used is the non-selective beta blockers like nadolol or propranolol may be prescribed, and the lactulose can be helpful in treating the confusion and other mental changes that are associated with the encephalopathy. Next. Next is the lifestyle changes. So maintaining good nutritional habits and keeping a healthy lifestyle will help in avoiding the portal hypertension. And we also have to improve the functions of the liver. And as we know that if the liver is healthy, then the body will also be healthy. Then we should avoid taking the over-the-counter drugs or the herbal medications without the doctor's consultations. And we have to follow the dietary guidelines as it has been advised by the doctor or the nutritionist. And we have to reduce the protein intake. Next slide. The other treatment options that may be available is the TIPS, that is the transjugular intrahepatic portosystemic shunt. In this process, what we do is we are placing a stent in the middle of the liver, and this stent connects the hepatic vein to the portal vein. During this procedure, a radiologist makes a tunnel through the liver with a needle connecting the portal vein to one of the hepatic veins, and this helps as to drain off the excess of the fluid that has been accumulated. Next. This is an image showing the transjugular intrahepatic portosystemic shunt. Next is the distal splenorenal shunt, also known as the DSRS. It is a surgical procedure during which the vein from the spleen, that is the splenic vein, is detached from the portal vein and it is attached to the left kidney, that is the renal vein. And this surgery selectively reduces the pressure in the varices and controls the bleeding associated with the portal hypertension. It is usually done in the patients who are having a very good liver function. Next. Next is the devascularization. That is, it is a procedure that removes the bleeding varices. And this is done when a TIPS or a surgical shunt is not possible or it is unsuccessful. And the next procedure that can be done is the paracentesis. That is a procedure wherein we are removing the excessive fluid that has been accumulated in the abdomen. And the last one, what we can do is the liver transplant. This is usually done in the case of end-stage liver disease. So the next topic what we'll see is the hepatic failure. Liver failure is a severe deterioration of the liver function, and it occurs when a large portion of the liver is damaged beyond its repair due to any type of liver disorder, leaving the liver unable to function any longer. And it is a potentially a life-threatening condition and it requires an immediate medical care. Next. Causes and risk factors may include hepatitis B, hepatitis C, long-term alcohol consumption, liver cirrhosis, malnutrition, acetaminophen overdose, ischemia or veno-occlusive diseases, viruses including hepatitis A, B, and C, reaction to certain prescriptions or the herbal medications, and ingestion of poisonous wild mushrooms. Stages of the liver damage. So first of all, the healthy liver may convert into a fatty liver where there will be more accumulation of the fat in the liver. Slowly, there may be fibrotic changes, so leading to the liver fibrosis, and ultimately there will be cirrhosis of the liver and the liver gets damaged. Next is the clinical manifestation. So as we have seen in maximum of the GI disorders, the nausea, vomiting, diarrhea, these were common. So similarly, here also the patient is showing the manifestations of nausea, loss of appetite, fatigue, diarrhea, jaundice, ascites. The patient will bleed very easily, abdominal pain and swelling. The person will complain of pruritus, that is itchy skin, dark urine color, bloody or tar colored stools, mental disorientation and confusion, sleepiness and coma. The systemic manifestations may include, that is hepatic encephalopathy, brain edema, intracranial hypertension, acute lung injury, adult respiratory distress syndrome, cardiovascular collapse, endothelial dysfunction, then the ileus, then portal hypertension, pancreatitis, adrenal insufficiency, renal dysfunction, muscle catabolism, immunoparesis, neutrophil dysfunction, and systemic inflammatory responses may occur. Next. The diagnostic evaluation. Here we may perform the blood test, then the liver tissue biopsy, which may be indicative of the fibrosis of the tissue and necrosis. Then is the Doppler ultrasound, CT, MRI scan, and electroencephalography may be performed in order to assess the function of the brain. The management, it includes medications to reverse the poisoning. Liver failure caused by acetaminophen overdose or mushroom poisoning is treated with drugs that can reverse the effect of toxins. Antidotes such as penicillin G, activated charcoal, N-acetylcysteine neutralize the toxic agents and neutralize or counteract any form of poisoning. Hemodialysis can also be performed in order to remove the toxins from the body. Relieving excessive fluid in the brain, that is the cerebral edema, which is caused by the liver failure, can increase the pressure in the brain. So here we need to administer the osmotic diuretics such as the mannitol, which is help in reducing the fluid overload that has developed into the brain. So here the intravenous mannitol may be administered in a bolus dose of 0.5 to 1 gram per kg of body weight or 50 to 100 grams in order to relieve the cerebral edema. Next. Next is screening for the infections. So here we may screen for the signs of infection and we may prescribe the medications by performing the culture and sensitivity test. Next is preventing the severe bleeding. So the people who are suffering from the liver failure often have the tendency to develop the bleeding disorders, especially in the GI tract. So here the doctors may prescribe the medications to reduce the bleeding. And next is the liver transplant. So if the liver failure is very severe and the process cannot be reversed, so in this situation, the final treatment that remains is the liver transplant. So here the surgeon may plan for replacing the liver with a healthy one. Next is the nursing management. The patient usually receives limited IV fluids and food that contains the sodium because sodium intake makes peripheral edema and ascites worse. And a paracentesis may be performed, removing 4 to 6 liters of fluid per day. And if the ascites is refractory, surgical placement of a peritoneal or venous shunt may be needed. Hypokalemia may be corrected by giving the IV replacements. And if respiratory failure is present, the patient may need endotracheal intubation and mechanical ventilation with supplemental oxygen. Next. The bed end of the patient may be elevated by 30 degrees to 45 degrees in order to ease the respirations. And next, to manage the nutrition of the patient, we may give 80 to 100 grams of protein per day in order to enhance the cellular repair. And in case of hepatorenal failure, it will be treated by fluid restriction, maintenance of fluid and electrolyte balance, and withdrawing the nephrotoxic drugs. And renal dialysis may be done if it is needed. Next. The next topic what we'll see is the cholecystitis, that is the gallbladder inflammation. Cholecystitis is the inflammation or swelling of the gallbladder. It can be acute, that is sudden in onset, and it can be even chronic, that is present from a long time or long duration. And it is usually associated with the presence of stones in the gallbladder. That is, if a person is having polylithiasis, the chances for cholecystitis increases. Next. Causes and risk factors is gallstones, tumors, bile duct blockage, infection, and blood vessels problem. Clinical manifestations may include fever, nausea, vomiting, anorexia, tender breathing, fat intolerance, feeling of fullness, acute severe right upper quadrant pain, and the pain may radiate towards the back, which increases with breathing. Diagnostic evaluation includes abdominal, ultrasound, X-ray, CT scan, oral, cholecystogram, gallbladder radionuclide scan, which is done to confirm the diagnosis and for ruling out any other possible causes. Blood test may be used to look for the signs of infection, obstruction, pancreatitis, and jaundice. The management is the immediate hospitalization of the patient. And once the patient has been hospitalized, we need to give the fluids containing the salts and sugars through a needle which is placed in a vein, that is called as IV cannulation. And no food or drink is given by mouth. Then the Doctors may prescribe the pain medications and the antibiotics in order to fight the infection. And meperidine is a drug of choice for the pain control. And the antibiotics, what may be administered is ampicillin, piperacillin, tazobactam, etc. for fighting the infection. And other than that, in the case of a life-threatening situation, imipenem and meropenem may be given. Next. The main treatment for acute cholecystitis is surgery, that is to surgically remove the gallbladder, which is known as cholecystectomy, or is the ERCP, that is endoscopic retrograde cholangiopancreatography, in order to remove the stones from the bile duct, and oral chenodeoxylic acid or ursodeoxylic acid may also be given to dissolve the calculus. Next is your polylithiasis. Polylithiasis is nothing but these are the stones that has been formed in the gallbladder. So it is the medical term that is being used for the hard deposit, that is the gallstones that may be formed in the gallbladder. Gallstones usually form from the solid constituents of the bile and may be as small as a grain of sand or as large as a golf ball. The types of gallstones are cholesterol stones. This is the most common type, and it is formed because of the presence of too much of cholesterol in the bile. And next is the pigment stone. The pigment stone is formed because of the excessive bilirubin, which is nothing but a waste product which has been created by the breakdown of red blood cells in the liver. Next. So here there are the various stones you can see. The cholesterol stone, the pigment stone, as well as the mixed stone. Next, the causes and risk factors. So during pregnancy, failure to empty the bile appropriately by the gallbladder, then the biliary tract infections, liver cirrhosis, that is the scarring and the poor functioning of the liver, sickle cell anemia and chronic hemolytic anemia, diabetes, that is eating a very low calorie diet leading to rapid weight loss, overweight or obesity. These are the causes. Factors that may increase the chance of gallstones is having a sedentary lifestyle, eating a low fiber diet, having diabetes, being overweight or obese, losing weight very quickly, and family history of gallstones. Clinical manifestation. The person will be complaining of pain in the middle or right upper abdomen that may be episodic, sharp or dull, and cramping, and attacks soon after having a meal and may spread below the right shoulder or to the back. Abdominal symptoms that occur within minutes after a meal, abdominal swelling, distension or bloating, abdominal tenderness, gallbladder becomes distended, inflamed and infected, clay-colored stools, low-grade fever and chills, loss of appetite, nausea with or without vomiting, sweating, presence of fat in the stool, also known as steatorrhea, and yellowing of the skin and white of the eyes, that is jaundice. Next is the diagnostic evaluation. So here we will be doing the ERCP, that is the endoscopic retrograde cholangiopancreatography. And then the blood test may be done to check the liver functions, the bilirubin levels, and the pancreatic enzyme levels. Then the endoscopic ultrasound may be performed, or else the abdominal ultrasound. Then gallbladder radionuclide scan may be done, abdominal CT scan, cholangiography, and percutaneous transhepatic cholangiogram may be done. Management, the pharmacological therapy, that is the ursodeoxycholic acid and the chenodeoxycholic acids are the drugs that helps in dissolving the cholesterol gallstones and they are given in the form of pills. And the main drawback of using them is that they may take 2 or more years to work efficiently, and the stones may form again after the treatment ends. In the patient with established cholesterol gallstones, treatment with ursodeoxycholic acid at a dose of 8 to 10 milligrams per kg of body weight per orally in 2 to 3 divided doses is given. Next. The non-surgical removal of the gallstones is the dissolution therapy, that is dissolving the gallstones, and this may be done by the octanine or the methyl tertiary butyl ether into the gallbladder through a tube or a catheter inserted percutaneously direct into the gallbladder that helps to dissolve the stones. And stone removal by instrumentation, that is, it is a non-surgical treatment for the cholelithiasis, which involves placement of a catheter through the percutaneous transhepatic cholangiography route. And through the guided fluoroscopy, the catheter is directed towards the stone, and basket is threaded through the catheter, opened, and the stone is trapped into it, and then it is withdrawn. Next. The second procedure involves the endoscopic retrograde cholangiopancreatography. So this is the image representing the endoscopic retrograde cholangiopancreatography. Here, this treatment allows to remove the gallstones that were causing the obstruction. You can see a guided wire has been inserted, and with the help of this, the gallstones are being removed. Next. Next is the extracorporeal shockwave lithotripsy. In this procedure, again, the shock waves are being given with the help of the lithotripsy machine. So here the shock waves are focused towards the gallstones, which helps in breaking them into the smaller pieces, and then it can pass out through the gallbladder, through the cystic duct, into the common bile duct, and then into the small intestine. Next. This is the image showing the lithotripsy procedure. Next. The surgical management, that is the cholecystectomy, may be done. Here, it is usually done as an means previously it was done as an open surgery for the removal of the gallbladder, but nowadays it can be done even laparoscopically, which is known as a laparoscopic cholecystectomy, wherein with the help of a laparoscope and the camera, the gallbladder is being removed. Next. So this is the open surgery on one side, and on the other side is the laparoscopic cholecystectomy surgery, wherein we are making various holes in and around the liver, and with the help of this, we are removing the gallstones. Whereas previously, a big incision was being made, and the stones were being removed from the gallbladder. Next. Next is the endoscopic retrograde cholangiopancreatography, which is both a diagnostic procedure also, and it can also be used as a surgical procedure. So if we need to diagnose a gallstone, we can perform the ERCP. And if we need to perform a surgery also, we can use the ERCP, wherein with the help of the endoscope, we will be able to successfully remove the gallstones. Next. Next is the GERD, also known as a gastroesophageal reflux disease, wherein the gastric contents are refluxed because of the means dilated esophageal sphincter. Come to the next. Gastroesophageal reflux disease is a chronic condition where the stomach acid flows back into the esophagus, causing heartburn and the other symptoms. The causes may be a weak or damaged wall between the stomach and the esophagus, that is the lower esophageal sphincter, obesity, pregnancy, bulging of the top of the stomach above the diaphragm, that is known as the hiatal hernia, connective tissue disorders such as the scleroderma, delayed stomach emptying. Certain factors that may aggravate the acid reflux include smoking, eating large meals or eating late in the night, eating certain foods such as fatty and fried foods, drinking beverages such as alcohol and coffee, taking certain medications such as aspirin. The signs and symptoms include heartburn, that is a burning sensation in the chest that may rise to the throat. Usually it is confused with the MI pain. Next is the regurgitation, that is the food or the liquid coming back into the mouth. Chest pain, non-burning chest pain that may radiate towards the back. Difficulty in swallowing, dysphagia, and other symptoms may include sore throat, coughing, increased salivation, and shortness of breath. The diagnosis includes esophageal pH monitoring, which measures the acidity of the esophagus, and the endoscopy. That is, with the help of the endoscope, we can visualize the esophagus and the inner lining of the esophagus. Next, the management. The medications may include the over-the-counter antacids or stronger medications such as the proton pump inhibitors to reduce the acid production. And surgery may be indicated in case of severe cases wherein we may perform this surgery to strengthen the lower esophageal sphincter. And the lifestyle changes, that is, the person suffering from GERD has to maintain a healthy lifestyle, has to reduce the weight, avoid the food that trigger the esophageal reflux, and elevate the head end of the bed and avoid the smoking. Next. Complications may include esophagitis, that is inflammation of the tissue of the esophagus, esophageal strictures, that is narrowing of the esophagus, and Barrett's esophagus, that is nothing but a precancerous change of the esophagus. Next, in general, we'll be dealing with the nursing management of the patients with the gastrointestinal disorders. So the main focus is to relieve the symptoms, prevent the complications, and promote the overall well-being of the patient. And this can be done by following the various steps. That is, come on to the next slide. First is by assessment and monitoring. This is one of the most important aspects while we are taking care of a person. So first of all, we have to assess the client and then monitor the client regularly for any changes in the status of the client. So assessment may be done by collecting the history and performing the physical examination. And then we may monitor the vital signs of the patient, wherein we may check the temperature, pulse, respiration, and BP of the patient respiratory rate. It helps to identify any changes in the patient's condition. Then we have to monitor the bowel movements, that is how frequently the patient passes the motion, what is the color of the stools, and what is the consistency of the stools, whether the patient is having constipation or diarrhea. So we have to rule that out. And then we have to assess the hydration status of the patient so that we can identify whether the person is hydrated or dehydrated. And then we have to evaluate the pain. That is, the intensity, location, duration, and frequency of the pain has to be assessed. Next slide. Next is the symptom management, wherein after assessing the client, we have already gathered the information regarding the various problems the patient might be suffering. So the common problem that occurs in case of the GI disorders is the dehydration, that may occur because of the nausea and vomiting, or else maybe because of the diarrhea. So first of all, we have to maintain the dehydration and electrolyte balance. So for maintaining the hydration status of the patient, we may administrate the IV fluids in order to rehydrate the clients. And for again maintaining the electrolyte balance, we may give the IV therapy to the patient. Then is the nausea and vomiting. The nausea and vomiting can be controlled by giving the antiemetic drugs. And next point is to relieve the constipation. As we have seen that the maximum of the cases, constipation was one of the contributing factors for causing any of the problems. So the constipation can be relieved by giving the fiber-rich diet and increasing the hydration status of the client. And finally, by giving the stool softeners. Next. Next is the nutritional support. In the nutritional support, we are supposed to maintain the nutrition of the patient, where we have to give the adequate nutrition like the vitamins and the minerals as well as the proteins that are needed for maintaining the nutrition of the patient has to be included in the diet. And we have to see that all the dietary factors which are contributing towards causing the GI disorders, such as the fatty foods, that has to be avoided, the fast food has to be avoided. So the diet plan has to be made in such a way that the person takes small and frequent diet. And at the same time, we have to educate the patient regarding the taking of the medications, that is the proper dose, the proper time has to be maintained. And if any adverse effects are there, that has to be reported by the patient immediately. Next, the hygienic practices has to be maintained, where the person has to be taught about the hand hygiene and the other hygienic practices. And then the lifestyle changes has to be explained to the patient, because we have seen maximum of the cases alcohol and smoking were one of the contributory factors for causing the disease. So we have to ask the person to avoid smoking and avoid the alcohol consumption, and to reduce the weight, because obesity was also one of the causes. So the person has to reduce the weight, and for this the regular exercises has to be done. Next slide. Next is prevention of the complications. So the complication like dehydration can be prevented by giving proper hydration to the patient by giving the IV fluids or the oral fluids. And electrolyte balances can be maintained by giving the IV therapy. Infection can be controlled by proper use of the aseptic techniques, that is the hand washing procedures, isolation precaution, and prevention of the cross infections. And again, for the perforation, we have to monitor for the signs of perforation like abdominal pain, fever, and immediate medical attention has to be given. Next. That is the discharge planning. So here we have to explain to the patient about the follow-up appointments. As in the Indian scenario, many times the patient gets discharged, but they don't report back once again for the follow-up visits. So as a nurse, we have to see that we have to explain to the patient the importance of the follow-up appointments, so that the person can recover from his illness completely. Then we have to even explain to the patient about the medication management, the dietary modifications that are needed, and the lifestyle changes that the patient has to follow. Next. Next is the collaboration and referral. That is the interdisciplinary team. That is all the team members, that is the physician, the dietitian, the pharmacist, and the nurse together form this team. And together they may give the care to the patient. At the same time, if needed, the referral services should be available for the patient, so that the patient can meet the other specialist in order to cure his or her particular problem or disorder. Next. These are some of the nursing diagnoses that I have listed down in common, as whether it was peptic ulcer or hemorrhoids or whether it was liver cirrhosis or polycystitis. In all of these problems, we have seen that pain was common. So first diagnosis, what we can formulate is the acute pain related to effect of the gastric acid secretion on damaged tissue. This may be related to the peptic ulcer disease. And if we see it is cholecystitis, then there the acute pain may be related to the inflammation of the gallbladder or something like that you can formulate. Next is ineffective tissue perfusion. This usually occurs due to the decreased blood flow, which can be related to your portal hypertension. Next is anxiety, which is related to the acute illness that may be common for all the patients, those who are suffering from the GI disorders. Next is imbalanced nutrition, less than body requirement related to the changes in the diet. As we have seen in maximum of the cases, the person was either suffering from nausea, vomiting, and anorexia. So because of that, there may be either a risk of imbalanced nutrition, or in many cases, the nutrition status may be altered. So that time we can formulate the imbalanced nutrition less than body requirement. Next is readiness for enhanced knowledge related to the lack of knowledge. So usually the patients, those who are coming for getting the treatment or the care, lack the knowledge related to the particular disease condition and what are the measures that has to be taken. So under that circumstances, the nursing diagnosis, what we can formulate is readiness for enhanced knowledge. That is, the patient is ready to accept new knowledge. So this nursing diagnosis can be formulated. Next is the impaired skin integrity that may be related to irritation and breakdown from the hemorrhoidal swelling and friction. This can come for hemorrhoids also, fissures and fistula also. And the same can come as a risk for impaired skin integrity in all the liver disorders, because in the liver disorders, what we have seen is the patient was having the pruritus. Whether it was a liver disorder or a pancreatic disorder, pruritus was common in such patients. So there we can come up with a diagnosis, a risk for impaired skin integrity, because due to the frequent itching, the patient can cause a damage to the skin. The next diagnosis, what we can formulate is constipation. This is related to the avoidance of defecation or due to the pain. And then is risk for deficient fluid volume, risk for infection, risk for hemorrhage. So many more such diagnoses can be formulated. Thank you. Any questions?
If anyone has question, chat box is yours. Kindly ask your questions.
Thank you so much, ma'am. It
Yeah,
was
thank you, ma'am.
a great presentations. You could see in the chat box there are so many comments that they learned a lot from you, and
Thank you, ma'am.
the way you presented, by keeping the things that you are teaching to the students, it was very fantastic. Santosh SU sir was sitting in front of me while you were teaching here in my office, and he said that madam ne to bilkul, she prepared like, means she is in the class, students are in front of her, and I can see so many students, they are making the notes for your classes. So I really,
Ma'am, what I feel is actually I have even missed few of the things, especially the pathophysiology aspect, because when I had included the pathophysiology, it was further going ahead.
yes,
It
yes.
was because you had given me just 2 hours.
2 hours. It is tough to complete so many disease condition in 2 hours. It's
Yeah,
not
yeah.
easy task for you. It was
Yeah.
really a big task for you. They see everyone is writing in the, ma'am, I send a question. Okay, they have some question with you. What they are writing? Please sit up. Where is the question? Ma'am, your explanation way is best. We learned a lot, but where is the question? Pathophysiology or medication. Okay, pathophysiology is, I already, madam just mentioned that pathophysiology is very much, it is taking much time and we are bounded with the time. she is also feeling bad that she was not able to present the pathophysiology along with all the topics. So you can go through with the other books, and either we'll see in the second series. We'll request
Yeah, yeah.
madam for the pathophysiology.
Yeah, sure, ma'am. Yeah.
So thank you so much, ma'am. And
Yeah.
I 2 hours continue teaching, but really we enjoyed, and students really gained so much. And very rare peoples, they are having the webinar series in medical, surgical, and adult health. So they are gaining a lot. I must say they are gaining a lot. Many colleges they
Yeah,
joined
ma'am.
with one connection, and there are a number of students. They are attached with you, and they learn from you today this disorder series. So thank you so much, ma'am, on behalf of Samarpan and all the entire candidates who joined today, for your wonderful presentation and the way you taught them. It was just above the words. Thank you so much, ma'am. Please have
Thank
a
you, ma'am.
round applause for madam. Thank you so much, ma'am.
Yeah,
Thank
thank you,
you.
ma'am.
And in the future, definitely we will be coming very soon with the second series, and I hope that you will be joining us there also.
Yeah,
So,
sure, ma'am, sure.
we need some good जो स्टूडेंट्स को भी बहुत अच्छा फील हो रहा होगा कि देखो ऐसा मैथ्स का टीचर्स हमारे पास है. सो आई कैसे भी करके ऑनलाइन सही दे आर एबल टू सी यू, दे आर एबल टू लर्न फ्रॉम यू. सो यू आर गिविंग मीन्स directly or indirectly so much to the students. So being a good faculty.
Ma'am, I'm always happy to do that.
Yes,
But
yes.
today what I felt was I was not able to teach them the pathophysiology.
Surely we'll give
Yeah.
some other time, means either in the second series, if
Yeah, sure.
means any break in any, definitely take you for the pathophysiology.
Yeah, sure, ma'am, sure.
लंबा हो जाता है वो. So
Yeah,
thank you so much,
anytime.
ma'am.
Yeah, thank you, ma'am.
Question in the chat box except pathophysiology. So everything was very much understandable way, because everything was like the definition, risk factors, sign and symptoms, causes, management. One by one, you put it like yes, Lipin cord style. So it was showing all the messages view. Yes, हाँ कह सकते हैं देख करके कि मैडम बिल्कुल अच्छे से सेट किया है. So thank you, ma'am. Take care.
Yeah.
We'll definitely meet again. Take care.
Yeah, sure, ma'am,
Next
sure.
time. Be
Yeah.
safe. Bye bye, ma'am. Bye bye. Take
Yeah.
care.
Yeah, thank you, ma'am. Thank you.
ठीक है.
ठीक है.
वो तो points देना था किसी को तुम दे दो.
Thank you, ma'am.